Okay, welcome to our virtual SID conference, where we have invited some of the speakers who were scheduled to participate in the SID meeting in Scottsdale present to us regarding aspects of Pachyonychia Congenita. Albert Wu, who's at the New York Medical College in New York, did some original investigation of the nail changes in Pachyonychia patients. Albert worked under the direction of Dr. Lipner, who's one of the U.S. experts in nail disease. And this is an area that is basically underserved in terms of our information on Pachyonychia. We have concentrated on the pain and the callus formation and other aspects of it, and we know the nail is part of that syndrome, but there's been less information known about how best to take care of those nails and what kind of changes we would expect to see in different mutations. And so, Albert, we're delighted that you would share that with us on a recorded basis so that we can use that in terms of training and teaching and research in the future. So I'll turn the time over to Albert Wu to talk about nail disease and Pachyonychia.
Okay, thank you so much, Dr. Hansen. So I'm going to be presenting on multiple distinctions in the profile, impact, and management of nail disease in Pachyonychia Congenita subtype. And we have no conflicts of interest to disclose. So a bit of background first. Pachyonychia Congenita, or PC, is an autosomal dominant dermatoses due to heterozygous mutation in 5 possible keratin genes: PCK16, PCK17, PCK6A, PCK6B, and PCK6C. Its exact prevalence is unknown, with estimates of 7,000 to 10,000 cases total worldwide. And the genetics of PC are complex and affect multiple aspects of the disease, including symptom severity and age of onset. Because of this, there is a large spectrum of possible clinical profiles and a wide range of clinical findings, including hypertrophic nail dystrophy, palmar plantar hyperkeratosis, pilosebaceous cysts, and neuropathic pain. These symptoms lead to lifelong debilitations and a negative impact of quality of life for patients due to severe pain and susceptibility to the infection. So for this study, the questionnaires and data were provided by the International Pachyonychia Congenita Research Registry, or IPCRR, through the Pachyonychia Congenita Project, PC project. This questionnaire included a number of items on patient symptoms, diagnoses, family history, and treatment. We analyzed patient responses completed between April 2004 and January 2019, totaling 857 responses to the questionnaire and 102 responses to the questionnaire addendum. The final extracted data, including thickened nail numbers, age of onset, treatment methods, and infection rate. Our primary objective was to characterize the breadth and extent of nail disease, treatments, and quality of life in PC patients, and to describe any significant differences in clinical presentation or treatment of PC subtypes. So this graph is just showing the survey responses. As you can see, survey responses were evenly distributed in sex and age. So the first part of our analysis calculated the frequency of each PC subtype. We found the most common subtype was PCK6A, followed by PCK16 and PCK17. The least common PC subtype was PCK6C, and you can refer to this table for the exact proportion. Regarding our analysis of affected nails in PC, the overall proportion of patients who reported thickened fingernails was 648 out of 857, or about 75%, while the proportion of thickened toenails was about 96%. Of the PC mutations, PCK6A had both the highest average number of thickened fingernails and toenails, as well as a significant proportion of patients who experienced nail thickening within their first year of life. On the other hand of the scale, mutations in K6C corresponded with the lowest average number of fingernails and toenails thickened. And again, you can refer to the table for the exact proportions. So the following slide will refer to this figure, and you may come back to it if needed. We found that PC subtype also differed in the symptom age of onset, For gene defects in K6A and K17, over 73% of patients experience fingernail or toenail thickening within their first year of life. In contrast, PC from mutations in K16 or K6B had a more normal distribution, with the majority of thickening onset occurring between the ages of 1 and 9. Overall, however, by age 10, 83% of all patients had experienced nail thickening of some kind. This data here on this slide was taken from the addendum, which is why the number of responses is fewer. We found that there was a large spectrum of nail discoloration in PC patients. Yellow was the most common discoloration overall and the most common toenail discoloration, while brown or tan was the second most common discoloration overall and the most common fingernail discoloration. The remaining spectrum of colors, including gray, black, and green, made up very few cases overall, in fact, even rarer than having a normal or unaffected nail. To further examine the emotional impact of PC symptoms, we organized the responses to a series of questions pertaining to emotions experienced by PC patients. These questions specifically asked if and when patients felt bothered, self-conscious, or embarrassed by the appearance of their nail. After tabulating responses to these questions independently, they were grouped into one supergroup named emotional distress to increase statistical strength. The highest proportion of responses of never distressed, indicating that patients never felt bothered, embarrassed, or self-conscious about their nails, occurred between the ages of 1 and 5 and dropped sharply after that period, while the highest proportions of always or often or frequently distressed about their nails rose steadily, peaking between the ages of 12 and 20. Importantly, the mutations which were associated with more extensive and earlier onset of symptoms were not necessarily associated with higher proportions of always distressed patients. In fact, these numbers were fairly evenly distributed. In our analysis of the effectiveness of common methods used for nail maintenance in PC, we observed the absence of a standardized maintenance protocol for thickened nails. There was a large variation of survey responses, with over 35 unique combinations of tools reported in the survey. The most common methods to manage thickened nails were clippers only, clippers and razors, and clippers, razors, and sanders. Among these, use of a clipper and razor, scalpel and clipper, or sanders only was associated with the lowest infection rate. To better quantify the infection rate and overall emotional impact on PC patients, two weighted scores were used: overall infection rate, OIR, and daily life impact, ELI. These considered more frequent occurrences to be more significant. In other words, tools associated with more reports of frequent infection or having nails still constantly impact daily life activities were weighted more heavily. Under these weighted scores, the method with the highest overall infection rate became use of clippers only, while the method with the highest daily life impact was the razor standard clipper combination. This slide just summarizes what I said in the last slide. I would just like to point out that each tool had a 2 to 3% infection rate individually, with no tool being tied to significantly higher or lower infection rate. This slide summarizes our results. Our findings confirmed previous reports of gene-specific PC disease courses. PC K6A having an earlier onset and more severe disease symptoms, PC K6C having milder clinical manifestations than other gene defects, PC K16 correlating with more digits affected, earlier age of onset, and more variation of symptoms. We also made novel observations on PC subtype differences. PC K17 and K6A appear to have an earlier onset of nail disease within the first year of life. PC K16 and K6B have the largest range of nail symptoms. And we also quantitatively confirmed that PC has a negative psychological and overall quality of life impact on patients, peaking in early adolescent years. Over half of patients reported at least some type of psychological distress. Most patients reported negative psychological experiences during childhood and adolescence. And self-management of PC symptoms has led to a wide variety of methods to treat dystrophic nails. All methods have similar infection rates and impact on daily life. To summarize our discussion, our findings confirmed previous reports of gene-specific PC disease courses. We also made novel observations on PC subtype differences, and we found that PC has a negative psychological and quality of life impact on patients peaking in early and adolescent years. We also found that self-management of PC symptoms has led to a wide variety of methods to treat dystrophic nails. In conclusion, PC subtypes have distinct clinical nail profiles and psychological impact. Cases should be approached individually, and therapeutic options should be tailored to the patient. Genetic testing should be used to confirm PC diagnoses. Further characterization of PC, especially the rare subtypes, may allow for more individualized patient treatment and education. We are truly grateful to the Pachyonychia Congenita project for the data and their support on this project, and we are indebted to all the patients with PC who participated in IPCRR.
Albert, thank you very much. If we were in a large group, we would invite questions from the audience. I just have a couple of short clarification kind of questions.
Okay.
Did you look at nail infections relative to age? The reason I feel like these happen in kids but don't happen in adults very often.
So we didn't look at nail infection specifically in regards to age. We looked at nail thickening onset with regards to age, and then we looked at nail infection rate with regards to use of tools or nail treatment. But that's something we can certainly look into in the future. But it does appear that most of the symptoms of PC do start appearing in childhood or adolescence, so it would make sense for infections to also peak around that time.
Did you talk at all about how to manage those infections? In other words,
we did not look into the management of infections. I guess the objective of our study was to look at the tools that patients were using to manage their symptoms currently, and then seeing if any of those were linked to higher or lower infection rates.
And if you were going to talk to a group of PC individuals, do you have a recommendation as to what you think would be the best way to manage their thickened nails?
Sure. So I would recommend that they use whatever combination of tools they are most familiar with. I think the most important thing that we found in our study was no tool was individually linked to a particularly high or low infection rate. And this suggests that it's most important for the patient to be familiar with the tools that they're using and most comfortable handling them. So I would recommend any combination of tools that they were most comfortable with. As I said before, some of the most common used tools were clippers and sanders, but any combination of tools that they felt comfortable handling and using was what I would recommend.
Excellent. Albert, thank you very much. I should note that Albert's a remarkable second-year medical student. He sounds like a resident in dermatology, but this is a very helpful aspect of PC, and that information will be helpful for us in terms of moving forward and talking to individuals about how best to manage their condition. So thank you so much for sharing that with us today.
Thank you so much for having me.